Hello everyone, and welcome to the Quorum podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Averick O'Kelly. This week we are giving you, the listener, a sneak preview of some of the lectures and presentations that we had during the Medicine in the Mediterranean conference held a fortnight ago. I chose 9 lectures to include in this week's podcast. If you missed this conference, or if you would like to hear again the amazing wisdom and experience from our presenters, we will be hosting the lectures on our Moodle site for purchase and download. We hope to have that up in the next fortnight. Now, our first presenter is Eric Bauer, who will talk about ventilation in austere environments.
The first thing is positive pressure. Factors, P, positive pressure. Well, obviously we have to ventilate our patient, don't we? And we ventilate our patient in multiple ways. That's not even talking about ventilating our patient in the peri-intubation phase, where we know that the standard of care has moved to passive oxygenation techniques, maybe withholding a BVM, using it as a last-ditch effort. But what about after our intubation is successful? How does positive pressure ventilation impact our patient's hemodynamic status? And so that is where, when we look at, there is definite research, evidence base to support the impact of positive pressure. Now, it's inevitable. We have to perform positive pressure ventilation. But what is the best way to do that? It's with a mechanical ventilator. And many of us, based on maybe where we're at, how we transition after intubation, we're using our BVM. Well, what's the impact? Well, we know based on standard negative pressure breathing, when we drop our diaphragm, negative intrathoracic pressure, that volume goes in, it actually optimizes forward flow. It optimizes preload. It is really good for your right atrium and right ventricle. When you then transition a patient to positive pressure, you limit this process. Preload drops. That positive pressure impacts your patient. And that's not even considering maybe the current disease process, why you're there, how the patient's heart is currently. Are they already in a cardiogenic type shock? What type of shock state are they in? So a lot of us use this, don't we? I call this the lethal weapon, because we all need to have continuous education on performing good quality BVM ventilations. And there's been a lot of great studies out there where they demonstrate, it doesn't matter if you're an EMT, an EMR, a paramedic, a nurse, or a physician, if you test them, we do poorly. Even knowing you're going to be tested, you still do poorly. And so what do? We bag too fast. We squeeze too hard. We start going to the beat of our heart. Or we start talking to a colleague and start bagging too quick. And so we start driving up those inspiratory pressures. Once we get above 20, we know a lot of that volume passes the lungs and goes to the stomach. That impacts our cardiac output alone. So how much volume does a BVM deliver? If you're using 2 hands, and we know the evidence says up to 1,500 mils can be delivered in one breath. Do we need that much? No. So that's a big problem. And so what's the solution? The solution really comes down to transitioning to a mechanical ventilator as quickly as possible. Now, I know that that's not always available. But if it is available, we have to do a good job in thinking about maybe changing our practice. And I'll give you an example where I see this really impactful. In the US, when you talk about flight crews, if they intubate in a hospital, they're going bedside to bedside, they have their ventilator with them. But if we land on scene of a scene flight, and we're dealing with a multi-systems trauma patient, and we go to the back of the ambulance, most flight crews are leaving that vent in the helicopter. And they're bagging back to the helicopter. And that's a really important phase. And so could we reduce the impact by having consistent tidal volumes, consistent rates?
Our next presenter is Dr. Daniel Grace, who will talk about human factors in pre-hospital care.
We're just going to talk a bit about human factors for the next 45 minutes or so. And each slide you could almost do a whole lecture on, or a whole module. So it is going to be a whistle-stop talk. Hopefully you've got your phones with you. That's not so you can play on them and not listen to me. But there's a few bits where you can scan a QR code, and then hopefully what you then type in will appear on the screen if the tech works. If it doesn't, we'll use good old-fashioned shouting. So just a bit about me. So I'm a GP by background. Portfolio GP, I guess that means that I don't really like sitting in a GP surgery. I'm seeing patients, so I prefer to do some of these other things. So a bit of travel medicine, a bit of basics and enhanced care with the Welsh Ambulance Service, a bit of mountain rescue, a bit of teaching, a bit of wilderness medicine, and so on. I've done a bit of work in Fiji with TV and film, done a bit of work in cold places, and last year I organised an expedition around Zambia, so if you're interested in any of that, this is not the talk for you, but we can have a chat in the bar. So hopefully if you get your phones out and scan that, or go to slido.com and click that code in, you will then be linked with the presentation, and a little bit later I will ask for some of your thoughts and we will get a bit interactive. So I'll just give you a few seconds to do that. Cool stuff, a few phones up. Yeah. Excellent. So, no surprise, who here worked pre-hospitally? I think pretty much everyone. Yeah, so there's these challenges, they're not going to be much of a surprise. We deal with difficult, unstable patients in difficult environments. We often have to think about our wider issues such as scene safety, difficult extrications, how do we liaise with other agencies, managing hypothermia. But these people, they're the biggest challenge of all, aren't they? If it was a situation where there were no people, it'd be hard to manage, but arguably easier in some ways, because we wouldn't have team dynamics, leaders, arguments, things like that. And I think human factors is fascinating. We were just hearing about how in a meeting there's that whole hierarchy and no one's actually going to say, go home, you're not well. But actually, it's not just medicine, it's not just pre-hospital work. Some of these lessons we can apply everywhere. Not least of all with our own families and partners. That's what my wife is. So, it's early. Let's talk to the person next to us. Ideally someone you don't know, say hello and all that. But just for 30 seconds or so, let's just talk to our neighbours about what we think human factors is. And then we'll kind of get into some more formal definitions. Don't be afraid, everyone here is really friendly.
Our next presenter is one of our own faculty from the Masters of Austere Critical Care. Dr. Sean Billowday will talk about needle decompression in pre-hospital care.
Okay, so I'm the one talk between you guys and the next coffee break. This is me, Sean. I'm a ER doc from the States. I work up in Maine. We'll show a map up in a minute. I do have one disclosure, and mostly thank you. You guys have seen Claire running around. She's almost 4, so she came with me. The movie will probably end mid-talk, and so I will have to restart said movie. So I appreciate you guys having patience with that, and also having patience with us kind of bouncing in and out of the conference over the past couple of days. I really appreciate that. I have no financial disclosures other than I brought my 4-year-old to Malta. This is what I'm going to try to talk about today. So we're going to look at needle thoracostomy, finger thoracostomy. I'm going to give you kind of my perspective on this and why this matters to us in the services that I work for. We're going to do this with some cases, some pretty cool CAT scans I was able to grab. And we're going to try to apply some evidence-based medicine to needle decompression. It's tough to do, but we're going to try. And the group I work with, we're currently working on a study right now to try to figure out how to teach the skill. And we'll talk about why that's important as well. And then hopefully come up with some sort of framework about what we should actually do in terms of needle decompression. This is kind of me, and this is why I was able to talk about this stuff. I am an ER doc, and so we do medical school, 4 years of emergency medicine residency. I was at Brown, which is in Rhode Island. I worked ground critical care transport. We do doc medic, doc nurse, two teams. And I'm currently the EMS fellow, which is when you go to medical school, residency, and then decide to continue getting no money and work for an extra year. And I focus just on pre-hospital medicine. So I spend 80% of my time in an ambulance or helicopter, and I work the other 20% in an ER. During residency, I also got my FOM, and so I have like that wilderness background. And then I'm currently doing the master's program here at Quorum. I did one of the eye care courses in April, and how I kind of learned about what this space is. And it's that really beautiful mesh of critical care, wilderness medicine, EMS, and so I'm kind of like diving into that as my career. This is where Maine is, by the way. It's way north. It's currently very, very cold. Like I got a call from a paramedic today that the blood in the IV was freezing when they were trying to put it in on a patient. And then Rhode Island is this thing work. It's very tiny little state right here, which is where I did residency. So mostly in like the Northeast. In the States, and particularly in my space, we have 2 different types of EMS systems, sort of 3, but really we have a 911 service, which is like, hey, I need help, call 911, and then the ambulance shows up. And then we also have critical care transport, which I know some of you guys folks work in that space. It matters because our protocols are all over the place in the US. And so what state you work in, what group you work for, are you critical care, are you paramedic based, are you AEMT based, it changes what protocols can do, or what protocols you are working under. And then in Maine, we're state-based protocols, meaning that every paramedic in the state functions under the same set of protocols. And then we carve out these little pieces for critical care transport and say, you're kind of special, you get to do other stuff. So as it pertains to needle thoracostomy, really, when you talk about finger thoracostomy, we're talking about carving out these spaces, and our critical care services are starting to do that. I want to just put this up real quick too, because I am not a surgeon, and you will find in the papers, if you look at this thoracostomy, thoracotomy are interchanged. We're just going to call this a needle thoracostomy or finger thoracostomy. We're also going to just say that needle decompression is what we guys do, right? We put the needle into the chest, and then anything that goes in the pleura, we're going to call that pleural decompression. So this is my world. Most of what we do in my systems is blunt trauma. Sometimes we're seeing penetrating trauma. In different cities, we're seeing more of that, but most of what we're seeing is actually blunt trauma. And so that matters because we really know that penetrating trauma and causes holes in lungs, and you can fix that pretty easily. Blunt trauma is a lot more vague for the paramedics to figure out on scene. And so it's not as simple, oh, there's a hole, put a chest seal on it. It's a polytrauma, and we're trying to listen to breath sounds with sirens going and people screaming. And so the idea that you can listen to breath sounds and figure out if there's an issue is kind of moot. And so I just kind of want to say that that's my preference or my perspective is we're just mostly blunt trauma. This is what we have. I have no connection with North American Rescue or anything, but these are mostly what people carry in the US. You either have the ARS, which is the kind of one I have the pointer on the right here. It's 3 1/4 inches, which is I think 5 centimeters. We have the Spears, which are 5 inches, which makes it 9 centimeters. And then this is just an angiocath, a 14 gauge. And so this is what our crews are carrying. Going back to thinking about why paramedics are doing this procedure, it's because they have suspected tension pneumothorax. And they're taught that if you don't have breath sounds and you're hemodynamically unstable, you're concerned for tension, and so you decompress the chest with one of these 3 things. The vast majority in the state of Maine anyways, the needle decompressions that we're seeing done are on trauma codes. And so meaning that there was a blunt trauma, the patient is in extremis or dead, they get needled on both sides, patient goes to the hospital, and the vast majority of those people die. And so that happens. The problem when I'm teaching paramedics is that I have almost no feedback about whether the needle was correctly placed or not. And so paramedics are doing the procedure and they're doing it, perceiving and they're doing it correctly, but I have no way of following that up because almost always if it's a trauma code, you get to the hospital and we just call it, we do nothing. Or you get to the hospital and you're in extremis, we rip the needles out and then you go to CAT scan. So I actually have no clue whether you got into the pleura or not. So we're gonna talk about some cases, 3 of them, where we actually have some nice imaging and try to understand what exactly it is that we need to teach paramedics on how to do the procedure and do it correctly. And the basis of our research study came up because I work for Portland Fire, which is an urban 911 system. The paramedics, they want finger thoracostomy because it's really sexy, right? And then I also work in the ER and I have other attendings saying, why are paramedics doing anything? They keep hitting the wrong spots.
Our next presentation comes from Tactical Medicine North, who are guests from Ukraine. We at the college have a close relationship with TACMed North. 3 of us faculty from Quorum went to Ukraine last summer and ran the Damage Control Resus Ukraine course. Here is Vlad Chumachenko talking about their experiences in Ukraine.
So, who we are? We are called Tactical Medicine North. My name is Vlad. I have Misha and Nastya together with me. We started this unit together. And what makes us different from most of you, you choose medicine as a part of your life. We didn't choose it. We had no choice. When the war started, the only choice that we made is that we want to fight for our country with the best that we can. And somehow it appeared that the medical or pre-medical part is the best area that we can help to our country, because most of us are mountain rescuers in the previous life and basic first aid instructors in the previous life. So we found a volunteer medical unit. Right now it grows little by little. The first baby steps were done with the support of MSB as a Swedish contingency agency, as a governmental agency that prepares Sweden to future conflicts and disasters. Right now we became a certified NAMT center in Ukraine, which is a great opportunity for us to bring the best training to our combat medics. We are part of the big unit which is called Extraordinary Tactical Medical Center. It's controlled by medical forces. It's a bunch of volunteer medical units who are recognized as a training and a medevac providers by Ukrainian Defense Forces. At some point, it will be in my presentation, we met guys from the Quorum, and right now we're proud to represent this DCR program in Ukraine together with Quorum guys. And we get a huge financial support from the project called American Rescue Project. They met us online and then offline and started to support our unit financially. So we are a volunteer medevac unit, and as I said, we had no choice, and we had this small video about the reasons that made us to combine that unit together.
Our next presenter is Dr. Trevor Abella. Dr. Abella runs the nursing department at the University of Malta. He will be talking about nursing care in pre-hospital environments.
Okay, to start wrapping up a bit, the most important parts. We usually as adults have a sense of control of our situations. Then something happens, an emergency happens, and it's unexpected. So there's loss of control, there's loss of autonomy. And there's a change in self-image or perceived autonomy. So what happens is that we don't contribute anymore to the interaction. Now, for good care to happen, whether it's nursing or something else, you need interaction and communication with the patient. The relationship is very, very important. And that relationship happens through trust. And I skipped 2 slides on purpose because I understand we're pressing, to talk about these 4 things. Very quickly. Number 1, respect. We need to respect the patients as fellow human beings. They are not there at our service, we are there at their service. Number 2, empathy. Empathy is a sore point for me personally. We don't know what empathy is. We think that by saying, hey, I know what, I can understand what you're going through, we're being empathic, or we're not. There was a good definition that I challenged quite a lot. Empathy is when you put yourself in the patient's own shoes. Who cares how you feel in the patient's shoes? What we care about is how the patient is feeling in his or her own shoes. I've passed through an experience with empathy, and we don't even understand how this pseudo-empathy affects trust. My second daughter was born still unexpectedly. And by empathizing, people started saying, now you have an angel in heaven, who cares? I want my angel over here. You're not the only couple to have been passing through this. People get on with it. The other one was, you know how many we see of these every month? That's fine. The consultant actually started stating the statistics. All in good faith to empathize, but we just lost trust. And both myself and my wife, we are both nurses. Yes, boring life. So, confidence, the confidence we project. If you're there with a needle and you're going to poke someone with a needle and you don't show confidence, there's no trust. And the interaction is very important. Understanding how interactions happen and how we interact with patients is fundamental for good nursing care to happen, small and nursing care.
Our next presentation is Dr. Ville Voipio, who is from northern Finland. He's a hemsdoc. I met him in the Sundsvall conference, the Tactical Trauma Conference in Sweden, last October, and he will talk to us about treating of the critical casualty.
I've been working in cold environments, like taking the kids to play ice hockey, doing extremely high altitude, low oxygen training, like skiing in Zermatt. And here you can see my kids, sub-Saharated, so they are carrying sand over of the youngest one. And we are also tougher than Vikings, and even our kids take ice baths on a regular basis, even in the summertime in Finland. And we meet quite a lot of venomous animals, dangerous animals who are sniffing cocaine, as you see, like flat-coated retrievers. And my extremely hostile environment consists of a Romanian wrestler. I think there were Romanians here as well. So, yeah, that's the one. Silvio Nastasa on the left side. He's now running a club in London. I visited there. He's two black belt on judo and jiu-jitsu. And on my right side you see a guy named something like Abrick. He's Johan O'Flanagan. I don't know how you say that name, but he's number 5 ranked grappler in the world at the moment, and then number 1 in Europe. And these are the young guys who beat the shit out of me every morning at 6:30 while training on the right side. Okay, I was asked to keep a lecture about my experiences in treating critically ill patients. And I got they said, just what pops into your mind, just tell us. So I started to think what to tell them, and I took the liberty to make a lecture how I've experienced treating critically ill patients. So now I'm going through some of the calls that I've been to or been involved. And I'm not trying to tell you that I've done quite a large job and tough places and things like that, but these are the things that kind of makes me what I am and how I experience things. The first call is to a place in a rural, urban area, as you see the roofs, urban area, where a man has fallen down the stairs, being drunk, and now laying down unconscious. We go there. The house was the biggest that I've ever been to. It was like you know the scene from Gone with the Wind, with the marble stairs going up and big paintings and things like that. And there was this man about 55, 60 years. He hit his head and drunk, unconscious. And his wife, of course, 20 years younger or so, was there. And I just said that now we treat your man, and we intubated and started to transport. And you know, it's just what we do. It's the basic thing: intubation and stabilization. That's medically quite narrow thing to do. And when I always try to think about the patient, also not only the patient, but the people around there, the relatives, bystanders. And I asked the lady when the paramedics started to take the patient to the ambulance, since it was in an urban area and we didn't do transportation by helicopter. I asked that, are you alone here? Are there anyone to keep you company? And then she said that our daughters are in the next room.
Our next presentation will be from one of our faculty. Vish Rajan runs our Year 2 of the Bachelor's in Remote Paramedic Practice, and he will talk about diving medicine.
I'm here to talk on hyperbaric misadventures or hyperbaric accidents. And for those of you all who do not know what hyperbarics is, has anybody been diving? How many divers here? That's awesome. So almost all of you all know what hyperbarics is. How many of you all have been in a chamber? Excellent. Those of you all who haven't been in a chamber, how did you all get to Malta? Did you all fly? Every commercial aircraft is a hyperbaric chamber because you're going to be pressurized greater than the pressure outside in the environment. So this is me. I do a fair bit of stuff. I have done a fair bit of stuff. Will not go too much into it. Not too many disclosures, excepting that I own a dive shop and I have a fair bit of endorsements for certain dive companies, and I teach at Quorum. So to start off with, I would like you all to think about the fact that most regulations, if not all, are written in blood, and primarily because you have accidents that people realize that there are problems and then go on into writing it into a regulation or a standard operating procedure. Hyperbaric misadventures, we had an accident yesterday in the US where a 5-year-old child died in Michigan in a fire and explosion in the chamber. We do not know yet why the child was being dived, and we do not know what table it was, but we do think that it is probably an off-label indication for the diving. We all know about Apollo 1, where the spacecraft chamber was pressurized and caught fire. If not, I'm going to cover it in one of my studies. And we have Tato, whose birthday, 49th birthday would have been 2 days ago. And unfortunately, he passed away in a chamber, which is a very unfortunate incident. Again, I'll talk about it as we go ahead. So my objectives are going to be talking to you all about a little bit of history of hyperbarics, which I know is going to be extra because almost all of you all understand it, but still we'll talk about a little bit about it. Approved indications for hyperbaric oxygen therapy. And I want to draw parallels here between how you have a formal indication and how you have informal indications and why people use them. Different types of chambers, and we'll talk about certain key accidents just to get an idea of what accidents can occur. We'll do a little bit of analysis, primarily talk about what has already been spoken about, human factors and stuff like that, and some recommendations. So the first known hyperbaric research was done by Robert Boyle, and he used an exhaustion chamber, or basically a vacuum chamber. He experimented on birds, but he first found it in a viper in a chamber, and he found a bubble that formed up in the viper's eye. And that's an exact quote from his article on it. So we had Reverend Henshaw in the UK, who was using a bellows for various kind of treatments as to increase the pressure, but it wasn't that much over atmospheric pressure. So he was the first person who used hyperbaric medicine, so to say, well before Robert Boyle started or talked about Boyle's law and any other thing. This is the drawing of Boyle's chamber, if you all have seen it, and the one on top, the circle on top is the evacuation chamber. Now, Paul Burt, we've heard about Paul Burt. Everybody knows about oxygen toxicity. So Paul Burt was the scientist who spoke about and talked about oxygen toxicity. Jacques Trigger, now he is an engineer who built the first caissons. And it's an interesting story that he was a geologist whose fiancée left him, and then he went into rock bottom, basically devising methods to mine rock from waterlogged soil.
Our next talk will come from Colonel Retired Matt Moront, who is a pediatric surgeon. Matt taught with Quorum last summer when we were running courses in Karlsborg, Sweden. He'll talk about pediatric trauma.
Okay, so I apologize. This is about urban trauma. I don't have any good statistics about rural trauma, but to give you an idea of what hurts kids and what kills kids in an urban setting, because that's where so many of them are seen. So if you look on the left, your left, this is the mechanism of injury. What you see here very quickly is MVA is motor vehicle accidents, PEDS is pedestrian struck, and falls are self-explanatory. I want you to kind of take away that if you, in an urban environment, those are the things that hurt children, okay? Lots of motor vehicle, and I always talk about motor vehicle related. If you think about it, being struck by a car, being hit on a bicycle, and being occupants in a car makes up a fair amount of that. And then you can see gunshot wounds, 7%, abuse, very important in young kids, under 2, actually under 1 mostly. Stab wounds and penetrating gunshot wounds are relatively small. Now let's look to the right side, what kills kids. And the difference is important. Falls is the best one. It's 30%. So we see a lot of kids with falls in urban environments, but they don't usually die that often, not as many.
Our final speaker for this week's podcast is John Christensen, who is a fellow Green Beret. I met John years ago when I was teaching the Tropical Medicine Week for the NATO Special Operations Combat Medic course. John was stationed there as an active duty physician's assistant for the U.S. Army. Today, John will talk about why mind matters.
All right, so it is an absolute honor and privilege to talk to you about why mindset matters. This is a personal as well as a professional journey for me. I just got back from 2 weeks in Boston, Massachusetts with an organization called Homebase, which works with veterans who are suffering from traumatic stress syndrome as well as traumatic brain injuries. My goal is to provide some tools for your toolbox as you work as remote medical providers. If you have ADHD, this is a slideshow presented for you specifically. If you don't, drink some coffee and try to keep up. So, can I get 45 minutes of your time after that introduction? Do I buy in? All right, well, you can all leave now and we can go to the bar. But if you get up during the presentation, I will write your name down and I will come talk to you later. No, I'm kidding. All right. I am not a psychologist, a psychiatrist, or an ancient philosophist. These are my opinions. They're based off my perspective of the evidence-based medicine of that program, as well as a recent article I just published that got published yesterday called An Analysis of Training of the Remote Medical Provider and Recommended Standards. There is a QR code at the end of the slide presentation with all my slides, as well as a reference to all my slides, as well as that article and some other Christmas gifts just because you're listening to me. I'd like to thank Sean Lauer for inspiring me to give this talk when he talked at the Wilderness Medicine Conference last year about psychological first aid. It's not my fault, the clicker's not working. So let's start with the end in mind. Why do you think mindset matters? What choices and decisions have you made in your life to end up in Malta 2025? Okay, let's go this. We could answer it with these 5 words. You become what you think. Lao Tzu said 2,500 years ago, watch your thoughts as they become your words. Watch your words as they become your actions. Watch your actions as they become your habits, and watch your habits as they become your character, and watch your character as it becomes your destiny. So what you think, can it actually lead to your legacy? Let's go behind the scenes and look into our mind to see our thoughts can actually shape our legacy. I want you to imagine that you're 5 years old again, and you would ask your parents, why? And you would follow that, but why? You had a curious mindset. It was your desire to understand and learn more. You're developing your analytical brain, part of your prefrontal lobe of your neural cortex. At this stage, it's really what separates us from other species, our ability to analyze, deduct, problem solve, have empathy, self-awareness, even contemplate our own existence and death. It's also the stage in your life that you're developing your personality by what you think, feel, and behave. This leads to what you say and what you do. And your actions are based on your values, whether that's nature or nurture, and your prior experiences. Your experiences come from your prefrontal, or they come from your temporal lobe, your parietal lobe, and your occipital lobe. It's your reflection of those sensory experiences that leads to your personality. But it's your perception of those experiences, whether they're good, bad, or even traumatic, that leads to your feelings and your emotions. Your personality develops your personal reality, but it has blind spots. I want you to imagine it's your first day of school. You're all excited you get to ride the school bus. You get on the bus, you're a cool kid, so you want to sit in the back of the bus. You sit down, bus driver takes off. The next thing you know, the kid next to you starts to scream. You look over and he had just kicked over a hornet's nest. Hornets are flying all over the back of the bus. They're stinging you, they're stinging the kids around you. You try to get away, but you can't. You're stuck on the back of the bus. This traumatic experience can lead to phobias later on in life, that every time you see a bee, you have an emotional response. But the reality is, bees are not hornets.
The speakers that you've heard today are just a preview of the words of experience and wisdom that you can find during our Medicine in the Mediterranean conference. We have all of these presentations and many more on our website for you to watch. Don't miss our next Medicine in the Mediterranean conference, which runs 30 January to 1 February 2026. Don't miss out on this fantastic experience. Next week, we'll return to our normal podcasting schedule.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.